outside. All right. Once again, Ayush, thank you so much for joining us on this interview. I would go straight to the questions. First off, we would like to explore a little bit about your background. You know, uh, what is your education background like? Can you sort of share just that with us?
Yeah, for sure.
Mhm.
Um, so I was born in the States. So I did my entire education has been here um, in the US. And so I finished high school like everyone, like most people, grades 1 through 12. And then I graduated and went immediately into undergrad, just 4 years for a bachelor's degree. Um, my degree was from the University of California, Berkeley. I did it from 2012 to 2016, and I majored in molecular and cellular biology with an emphasis in immunology and infectious diseases. And then I also minored in molecular toxicology. And then from there, I worked for about 3 years, two to 3 years. And then from 2018 to 2019, I did what's called a post baccalaureate, which is not a degree, but it's like a certificate. Um, it's usually meant for people who want to go into healthcare, pursue an advanced degree in healthcare. And that certificate took me 1 year to complete, so 2018 to 2019. And I did that at California State University, East Bay. And then after I finished that program, I applied to medical school, which I started in 2020 at the University of California, San Francisco. And I was working on that from 2020 to summer of 2023. So I had done 3 years. It is a 4 year program. And what some medical students do is they take a gap year. So after they complete their third year of medical school, if they're so inclined, they can take a gap year and go and pursue research for a year or go and pursue a second master's degree. And then when they finish that, they'll come back and they'll finish their fourth year of medical school, apply to residency, go through that whole process. So right now I'm in that gap year with you and your group mates, um, working on an MPH here at Hopkins.
Wow, wow. It sounds as if you jump into the medical school in COVID year, right? What was COVID the motivation, or what was it that motivated you to jump into medical school? I mean, I'm interested in learning the motivation, you know.
Oh man, it's a deep question. It goes back. Oh, COVID was not the motivation. Definitely
Okay.
not. It just so happened to be the thing that was going on when I got into medical school. But no, my my motivation goes back to when I was like 8 years old. Um, my uh, my family was involved in a car crash when I was 8, and my dad ended up with a spinal cord injury at the level of C4, C5, so like right here in his neck. So from here down, he's paralyzed, and so
Sorry.
that's all good. He was never one to miss out on a teaching opportunity. So he took his injury and used it as a teaching uh, opportunity for me and my sister. So he would take us to all of his doctor's appointments with him. Um, and he would also like take us with him to these town hall meetings in the city that we lived in. We would go there by foot, and he would bring us along with him. It was really hot because they happened usually over the summer. So we'd go from our little corner of the city, and of course, town hall was on the exact opposite corner of the town. So um, we would tag along with him, to those town hall meetings, and we would watch him advocate for accessible transport for people with disabilities, public transport, so buses and things like that, that were easily accessible for people with wheelchairs. So for me, I mean, I've been wanting to be a doctor ever since that accident. But I think what's maybe sets me apart from a lot of people who are motivated to go into medicine is that I grew up not only seeing like the clinical aspect of medicine, but also the community aspect of medicine. And at the time, I was really young, so I just called it finding medicine where there is no medicine, as in like I'm looking for ways to heal that aren't maybe found in like a hospital or like a clinical setting or through medications, but through like advocacy and organizing. And now that I'm older, I realize that that's public health. So the motivation to become a doctor went hand in hand with the motivation to get an MPH.
Wow. When you mentioned car crash, I could connect with you because this is one area that I've committed to, to fighting for and making making push, calling on stakeholders, government, and everyone who cared to listen, to pay attention to it. So I could really connect with that, and thank you for sharing that part of yourself with us. You know, um, you know, uh, so I would, will it be out of place if I say the car crash was one of the biggest motivation, as well as your dad taking you to the hospital?
Yeah, I mean, I think the results of the car crash were like the biggest motivation. Maybe not necessarily the car crash itself, but everything, every the car crash was a big inflection point in my life, and my family's life. It was definitely the thing that set the wheels in motion. Who knows, like if that hadn't have happened, maybe I would be pursuing something else right now. I don't know. But everything that I do now, I can tie back to that moment in my life.
Wow, wow. By this story, you've inspired and you've instigated something that I should start doing. Maybe after this conversation, I would let you know what it is. It just, while you were sharing the story, it just hit me. It's an idea, that hopes to respond to, uh, you know, road safety. So thank you for sharing that again. The next questions I would like to ask you is about your your plan. You know, now you're you took taking a break, to pursue an MPH, which would also allow you uh, outside the clinical part of medicine to also sort of help shape the future of public health. You know, what is your plan? What is your future plan? Do you hope to work in the hospital, and while also working in the public health setting? What is it?
No, I think you pretty much hit the nail on the head. I think um, for me, it's very much a desire to walk both paths. Um, I think some people pursue an MPH while they're pursuing an MD and they hope to remain clinical. Like they hope to just use their MPH to kind of guide their clinical practice and maybe dabble here and there in public health. But for me, I really see the two as much more intertwined and connected, and I would be doing myself and the people that I care most about a disservice if I weren't to follow both as equally as possible. So finding clinical time um, to see patients individually, but also um, working as a community organizer, community advocate, or community healthcare worker, and in a more public setting. I'm not entirely sure what that looks like or if that's even feasible, but that's the dream, and I've made it this far living on dreams, and it's working out decently well for me so far. So I'll find a way to do both.
Yeah, I mean, yeah. I mean, the ultimate thing is that the will is there. Once the will is there, the possibilities are there, and it's such a unique thing to find a medical doctor who is in the clinical setting and also out there ensuring that the community health are are protected and all that. So I think it's a unique thing, and I wish you all the best of luck. In terms of your uh, still on your future, what are your area of specialization? Are you are you going to specialize in certain area in your medical field or
Yeah,
what?
yeah, great question. This one I'm like dead certain on. I've been dead certain on it since I started med school, even before. Like I mentioned, when I was doing my undergrad degree at UC Berkeley from starting in 2012, I majored in biology with an emphasis in immunology and infectious diseases. So um, I've always been like really interested in infectious disease. That kind of stems from my dad having chronic infections as part of his like lifelong condition, um, but also interest in like the basic sciences of microbiology, virology. That's what I pursued a lot in undergrad. I did a little bit of research during that time in the host pathogen interactions of tuberculosis. So it started as an appreciation for the basic sciences of the field of infectious diseases, and then over time, I think by virtue of the fact that of the way that I grew up and that I went to a pretty liberal school like UC Berkeley, um, really kind of helped to, I wouldn't say open my eyes because I was already aware, but like really helped me to like narrow down and focus on like not just the basic sciences, but the social aspects of infectious disease. Um, so yeah, I would say infectious disease is my number one priority as a physician. And after medical school, I'll apply to a dual medicine and pediatrics residency. So I'll be trained in general medicine and general pediatrics. And then from there, I will apply to fellowship. And right now, I'm thinking of a dual fellowship of adult and pediatric infectious disease. I may change my mind and just go with adult infectious disease, but because the training is pretty long. But I like the idea of being able to serve everyone of all ages across the spectrum, um, as it pertains to ID. So that's the plan right now.
Well, thank you so much for sharing that. And I sort of connect to the point where you mentioned that you liked biology and microbiology. And I could sort of remember uh, the public health biology we took last time, how excited you were. And then you also inspired me, keep feeding me that this course is going to be easy, even when I didn't believe myself, you know. Fortunately, I made A. I didn't expect. It was one of the. It was one of the courses I thought I was not going to even come close to a B. But I took that. Your words, your inspiration, personal, and I began to work on it. And I'm happy that. But it's all begun from you. So thank you so much. You're already making the impact, man.
I'm happy to. I'll always hype you up, man. No matter whatever you need, I'll hype you up. You got this. Public health
Yeah,
biology.
yeah, yeah. So
Never gonna
like,
be a problem for you.
yeah. Thank you. So what are your thoughts on the shortage of healthcare workers in Maryland, more specifically PCP? You see, there's this big problem of healthcare workers. There's been research evidence that in the next by 2030 or 2050, it's going to be like a crisis in the US in terms of healthcare workers. Yeah, Maryland is facing this big problem. I think the figure is around 5,000, shortage of healthcare workers. So what's your perception in that? What do you think? You
Yeah,
know,
it's a deep question. Um, I don't know enough about Maryland to be able to speak exactly to the policies and interventions that need to be implemented or have been implemented thus far in the state specifically, but um, I am aware that like the lack of primary care is already a big problem and is going to continue to be a big problem. In my mind, there's a couple of different reasons. I'm sure there's plenty, but the ones that come to mind for me as a medical student right now are that if you look at the pay disparities, the wage disparities between, uh, I'll call them like proceduralists, that is, people who do procedures. So,
Audrey? So,
uh,
is it,
doc-
okay, go ahead, sorry.
yeah, like doctors, like surgeons or
Audrey, okay.
anesthesiologists, um, interventional radiologists, uh, people who are trained in those specialties make a lot of money. They make a lot versus people who are trained in primary care, uh, specifically like family medicine and pediatrics. Um, they make some of the lowest wages compared across the board to other specialties. And that is not to say that physicians are not well paid in this country. Physicians are very well paid in this country. But if you talk to a medical student, particularly maybe one who comes from a lower income background or what the medical school application would call disadvantaged, um, they you can understand why money is a huge motivator in what sort of specialty you pursue after medical school. So people are more incentivized to pursue non-primary care specialties because of the wage gap. Um, Another possible reason is that I don't know the exact figures, but from what I have read and understood, the amount of seats, um, the amount of medical school seats is greater than the amount of residency seats. So, not everyone who finishes medical school will find a seat in residency because there just aren't as many seats available or positions available. So we are missing out on some physicians, some future physicians, or just making their path a little more difficult when we don't have the training spaces available for them. Um, I would say those two are some of the bigger ones that come to mind. I would also say that um, there's just uh, also a disparity when it comes to geographical location. So a lot of people um, prefer to practice medicine in more urban areas, larger areas. So people gravitate more towards cities like San Francisco or New York or Chicago or Seattle, um, as opposed to practicing medicine in more rural communities where their health, um, where their care is like sorely needed, especially primary care. So, a couple different reasons. I would say the wage gap seems like the biggest incentive to not pursue primary care in my mind. And I could be missing other reasons, but those are the ones that come to mind.
Yeah, I think when we discuss this issue, one thing that is predominantly among all those that we've talked to is the issue of the wage issue. The wage gap is huge. You know, just like you've said also, not that PCPs, primary care physicians are not paid well, but when you look at the wage gap between a PCP and then maybe a specialist, you anyone is tempted to want to specialize in that area. So thank you. And then also talking about residents, I think it's one area that we need to also look at deeply, you know. So let's move on for the next question. Um, how do you think we can address and effectively manage PCP sharing?
Yeah, great question. I think, how deep do you want to get? I mean, we could we could obviously like pay primary care physicians more, um, and perhaps decrease the wages of proceduralist specialties. Um, but obviously, like that would be like super problematic. People would be very upset, and it's just not the way our healthcare system is set up right now. OR time is very lucrative, and so as long as that's the case, as long as our hospitals and administration and um, uh, those sorts of institutions continue to uh, garner more money through those types of interventions, that gap is always going to exist. So some other things that we could maybe consider are a better um, loan forgiveness program. Um, so medical school is extremely expensive, and students typically graduate. I don't know the exact number, but I would hazard to guess about $200,000 in loans by the time they finish their 4 years, and that's quite significant. Um, so if you were to institute a program that say um, uh, forgave the loans of people who go into primary care, that would be a huge incentive for a lot of people to go into primary care, is knowing that like, hey, even though I don't make as much as a surgeon, my loans will be forgiven. Like I will be taken care of if I pursue this specialty. And I think that's huge. Actually, those types of programs, I believe, already exist. So what I'm suggesting is making them more robust. Um, I believe that, like, for one of them, um, you have to work in like a federally qualified health center, or a rural underserved community or something for, I think it's like 10 years. So what if instead of 10 years we said like 5 years? What if instead of 5 years we said like 2 years? 10 years is a long time. 10 years is a long time for people to commit to working um, in a high demand and low resource setting, um, like an FQHC or a rural healthcare center. So making those systems more robust um, would be huge, I think. Another thing you could do is just make the cost of medical school less expensive. Um, I think it's really unfortunate that medical school is as expensive as it is. I think it actually serves as a barrier for a lot of
Mhm.
really incredible physicians to be, from following that path. And there's a huge like disparity when you look at medical schools often report like things like race in their like student admissions. So X% of the student body is like white, and like Y% of the student body is Asian, and Z% of the student body is black. And those statistics are interesting to know, but they often don't report the statistics surrounding which students are economically disadvantaged. Like how many of their students are coming from a background where they just like don't have funds, they don't have resources. Um, and I think if you look at those numbers, that disparity is even larger. So a lot of, I think in, again, I don't have the statistics, but from what I've heard and what I understand, um, a lot of students, even though they're coming from like underrepresented backgrounds in terms of like race, they're still coming from economically advantageous backgrounds. So the actual number of medical students that are making like, I don't know, below the federal poverty guideline uh, threshold or whatever their metric is for qualifying you as economically disadvantaged is quite low. Um, so I think that kind of goes to show that a lot of people aren't pursuing medicine. A lot of people that we really need aren't pursuing medicine just because it's too expensive. And
Mm.
um, I think it's also a big disadvantage.
Yeah, I think you've touched the chord, you know, um, in terms of costing, which you've mentioned, could really, discourage a lot of people, especially when you come from a low income background,
Yeah.
and this is one of the thing that cut across people who've talked about. Thank you for sharing that. How can training pathways be made more efficient? I know in the course of your responding to the question, you mentioned um, maybe access to funding, or maybe decreasing the funding, the cost of um, attending a medical school, or maybe forgiving loans. And one way to do this, maybe fellowship, provide more funding for PCP training, you know. So in other ways, how can training pathway, be made more efficient?
Yeah. Um, Great question. Ton of answers I could give you. Um, we talked a lot about finances, and obviously, like that's one way. Um, but I think there's a lot to speak to about just like opening more residency spots. I believe residency spots, like their funding is through Medicare or Medicaid, or I'm not sure where the money comes from, but hospitals are given money to open spaces, and that money comes from the government. And what the government needs to do is make those funds more robust or more available to hospitals to open more residency spots, so we can train more physicians. That's one thing that they could do. The second thing that they can do is decrease the barriers that international medical graduates face in doing their residencies here. So the match rate for IMGs in the US is like ridiculously low, especially for certain specialties. I think that's an unnecessary barrier, and I think it speaks to the bias of the US medical education system in thinking that these trainees just aren't at the same caliber or the same quality of like US medical graduates. Um, so that's another thing we can do to incentivize like physicians like coming here, training here, staying here, practicing here. Um, Another thing is get more medical students in, right? Um, and I'm not just talking like more like white medical students that have parents who are doctors. I'm talking about get more students from underrepresented communities into medical school. Um, and I think what that involves is like medical schools being more active in their communities. That's something I've thought a lot about is like I'm I consider myself from San Francisco. San Francisco is home for me. And if you ask a lot of like medical students, not many have the privilege of being able to say, I'm from San Francisco and I'm studying medicine in San Francisco. I'm learning medicine in the community that I grew up in, that I know that I want to like continue practicing in. People who grow up in a certain area feel a connection to that area often.
Hmm.
So wouldn't it be so great if, say, UCSF did more outreach in the San Francisco community to encourage more students in San Francisco to pursue medical school? And not only just to pursue medical school, but what if UC San Francisco like ensured that like a portion of their incoming medical students every year were from San Francisco? I think that would be incredibly powerful to, I mean, if I'm sure I know for a fact a lot of my personal friends who are doing medical school out of state. They grew up in San Francisco, they grew up in the Bay Area, but they're having to do medical school outside. Um, it takes a toll, and it's not their preference, and they would be much more successful and powerful and happier and healthier if they were able to um, pursue medicine in the place where they grew up and where they connected with. And not only that, the community would benefit because every year you get it. It's like what Hopkins teaches us, right? About
Hmm.
how in our class, our MPH class, we have one, maybe two students who are actually from Baltimore. And I think that's really upsetting. I think
Yeah.
people who are from that city, who know that city, um, they know the issues better, they know the needs a little bit more, and the community benefits when its community members attain power and privilege in that community. Um, so if there was a way to make it so that we could increase the number of medical students going to medical school in their hometown or in the nearby city, I think that would be incredibly powerful and a really good incentive. Um, yeah.
Yeah. Thank you for sharing that part. Yeah, I mean, it is helpful to sort of encourage domestic participation in areas such as medical school, but sometimes uh, there's a saying that says a king is not known in his hometown, so most times there are other challenges that could come with it, but I hope that helped. So finally, we've talked about well, increase funding, increase incentivize the process, the pathway for PCPs and all that. Do you foresee any challenges or obstacles with improving the shortage of healthcare workers?
Oh yeah, plenty. I mean, everything that I've suggested so far um, is something that I'm sure would not go over very well. And I think it's important to remember that um, a lot of these changes aren't up to hospitals or medical schools or even the uh, what is the institution called? The American Academy of Medical Schools or the AAMC or something. Um, it's not even up to them. Um, this is all tied into like policy and governmental level um, things. So uh, when you start talking about funding, when you start talking about loan forgiveness, when you start talking about admissions, like this involves a lot of other powers. And
Mhm.
so um, it's difficult to get things to move in the right direction. I also think that like the American Medical Association, which is like the largest like organized group of physicians, um, I mean it's a lobbying group. Um, it's got a terrible like track record of voting and lobbying efforts back. when slavery was a thing in the US, like the AMA was like in favor of slavery up until a certain point. Um, just recently, the AMA vetoed a resolution uh, that was brought to the floor by some of the physicians about calling for a ceasefire um, in Gaza. So the AMA, um, in my opinion, is not living up to its potential in uh, lobbying the U.S. government for appropriate changes, nor does it have the track record of really doing that. Um, and I think it's not utilizing its power very effectively either. I think the last time, I mean, if you think about it, physicians have a ton of power and a lot
Mhm.
of sway. And that power and sway needs to be used for good. And I think the last time that the AMA got together and like put out some semblance of like a statement on a recent issue was like gun violence back in 2016 when they basically said, "Hey, gun violence is bad. A public health crisis. Um, this sucks. We should do something about it." Like that's it. That's all they did. It's the largest organizing group of physicians in the country, and that's all they could muster up the courage to say. And I was severely disappointed in that. As I continue to be disappointed by it, the more I learn about it, and the more that I see how its actions are proceeding now. So I a lot of these institutions are very like set in stone. Um, it's very de-incentivizing for me to like even consider being a part of that organization or focusing my efforts on these kinds of things, and because I just feel like my time would almost be a little wasted, which is why I prefer to work more in community and less in like further like government or policy work. I would rather work with local organizations and local institutions and local communities trying to bring about change at a smaller level for the people that I care about, as opposed to trying to get the AMA to change something or do something or get senators to increase funding or whatever the cause is. I'm sure there are people who feel otherwise, and I think that they are better suited for that, and I appreciate their efforts. Um, but it's not necessarily for me.
Thank you so much, Ayush. The information you've shared with us is robust and would definitely go a long way to helping us recommend some solutions to PCP shortage through the Maryland government. And we hope that they would act on it and implement it because it's about the future of the U.S. um, medical record, and of course, at the long run, it would improve the health and well-being of the people in the United States. So again, thank you for taking this time to sit with us and giving us your audience. Uh, it means a lot to us, and we appreciate it.
Of course, man. Happy to help.
Thank you.
All
I
right.
have to end the recording now. Why do I do that?